Okay, chapter 54 is physical therapy and rehabilitation, and we will be having our PT day this week. And so a lot of these things that are in this chapter, you will be going through the physical therapy assistant students, and they'll be going through and instructing you. This is their area of expertise. And so they'll go through and give you ways on how to be able to explain these kinds of things to patients, because there may be a case scenario where you're having to deal with that and won't necessarily have direct access to a physical therapist to be able to explain these things. So some of the basic things on how to use crutches and a cane and a walker. They'll show you some treatment modalities for hot and cold. They might even do some wrapping, and then how to transfer patients as well. So those will be the things that you'll be dealing with this week with the physical therapy students. Okay, so a few of the other things that we'll be talking about this chapter are just sort of the general principles of physical therapy. They do talk about cold and heat therapies, the benefits, and also the contraindications. They'll talk about hydrotherapy, as well as some methods of exercise therapy that can be discussed depending on what kind of patient you're dealing with. There's a little bit that talks about massage in here. And how that can be utilized in rehabilitation therapy. They talk about traction and different case scenarios that you would use that. And then once again, the biggest thing kind of coming out of this chapter is how to transfer a patient from a wheelchair to a table and back again, as well as giving instruction on how to use a cane, walker, and crutches. And then looking at some of the responsibilities the medical assistant has when you're actually dealing with a patient that needs to be referred to a physical therapist, and where your role plays in those particular patients. So when we actually look at some of the things a medical assistant may be doing, there could be times where you have to know some of the different cold modalities or cryotherapy modalities, as well as heat, which are thermotherapy modalities. There may be times where you have to actually administer those. Prototypically, you're going to administer heat before cold because you don't want to freeze the skin first. It's always better to heat and then cold. And there are certain case scenarios where you'll only use one of those modalities. And then there may be other situations where you might alternate. And there can be benefits from alternating if you're with the right, when you actually have the patient issues can sometimes necessitate doing alternating treatment patterns. Definitely assisting with ambulation. So that's why we go through this chapter and why we have the physical therapy students come over and help you guys learn how to assist the patients with that. There may be times where you actually have to teach basic exercises depending on the scenario and the type of patient. And once again, the cane, the walker, crutches, and the wheelchair will be what we're doing in our class. And then you'll need to kind of understand these concepts and then be able to give at least basic instructions on how to use these therapies at home. So we actually look at the reasons why we might prescribe physical therapy or why it might be needed. There are definitely a number of musculoskeletal disorders, low back pain, knee pain, osteoarthritis, and it could be multiple different kinds of back pain, different musculoskeletal disorders. There can be nervous disorders as well. Someone with MS may need an exercise, might need an exercise routine. Someone that's had a stroke, that's a really large area where people have to go through a number of different kinds of not only physical therapy, occupational therapy can be used. And then there's some cardiopulmonary disorders as well, post-MI or post-heart attack. People with COPD, they found if they can get people to stop smoking, people that have, chronic lung changes from smoking for too long, quitting smoking and doing some low-key or low-stress exercises, light cardiovascular activity can actually help those patients with their musculature and even with their lung function. So there's a lot of different areas that you might deal with physical therapy and different exercise routines. And so being familiar with these treatment regimens, the basic treatment regimens, and some of the disorders that might necessitate that, as well as being able to understand and be able to explain why these are beneficial. A lot of times people think, I'm 75, I have COPD, why does it matter if I exercise? Letting them know that that can increase their longevity, it can help their lung function. It isn't going to reverse what's there, but it might make the time that they have left more comfortable and in a stronger, mental and physical state. And so being able to understand and explain that is important. Once again, everyone involved in this process, from the primary care to any of the specialists, if you've got an orthopedic involved or a neurologist, are all on a therapeutic team, and that includes a physical therapy team. So the idea is to make sure that we're treating the patient as a whole, and all aspects are being taken care of through all specialties. And a lot of times it's a primary care doctor and the medical assistant or the team that works with that primary care doctor that kind of acts as the base to this therapeutic team, making sure that that patient gets all of the referrals that they need, and that the best care is being given to try to maximize all the physical, mental, and emotional aspects of that patient's disease process. So things that you might end up doing are coordinating a patient's schedule. You might say, you know, we have a neurologist here, and you're going to need to go to physical therapy twice a week for 6 weeks, and then they'll reevaluate you. So kind of being able to put the patient's schedule together, definitely making referrals, documenting treatments and finding, making sure that you send for records and that updated records are in the chart so that when the patient comes back for a recheck, the primary care clinician's got everything needed to see what's been done. Reinforcing instructions is huge, because a lot of times you can't just tell these patients something once. You need to tell them once or twice, and then you need to write it down, and then you need to give them a number to call if they have any questions, okay? Because frequently when they leave the doctor's office, they forget half of what was told to them, okay? So some other things that you might be doing too is there could be a situation where you're assisting with the actual patient assessment. Obviously, you're not having to conduct the assessment by yourself, but you need to be familiar with what's going on during that assessment. And so when you're dealing with musculoskeletal issues, one of the first things you have to do is a joint mobility test. So you need to see which joints can actually move. And a lot of times they'll do just passive range of motion to see what that patient's passive movement is. And then they can also do active range of motion as well. There is a specific measurer called a goniometer, and orthopedics and physical therapists, and sometimes the primary care doctors will use this too. If you've got a specific joint, if there is a complaint that that joint doesn't move as well, then they have to do complete measurements, because there are extension, flexion, abduction, and adduction range of motion that can be checked, because most joints have a certain degree that they should be able to either flex or extend or what have you. And so it's important to measure that, and you can say, oh, this joint is, has 20 degrees less of, range of motion than your other joint. And so there is a comparison that has to be done, and there's a comparison to a standard. And so there are specific degrees that all of them, your joints should be able to move, and then they have to be assessed and documented if they're not considered normal. You also have to do muscle strength testing, where you're actually seeing whether or not the groups of muscles have equal and symmetric strength to them. And so as you flex or extend, if one muscle group is not as strong as the other, then that is something that can be documented and dealt with, because that could be a significant issue and may have to be addressed in the physical therapy. Okay, so you're always comparing one side to the other. All right. Gait testing is also important. You want to assess how a patient walks. And so if somebody has arthritis in the knee or the back, when you've got another common time to do gait testing is when you're dealing with someone like Parkinson's disease, especially in the elderly, being able to see whether or not they're a fall risk, and then being able to assess what might be an appropriate mobility aid. Does this person need a cane? Does this person need a walker? And so gait testing helps to determine, one of those things, whether or not you need an actual, mobility aid with this patient. Posture testing is also important too, because you're looking for position and alignment. You can check for spinal curves. Some of the curves probably were talked about when you're in anatomy and physiology. Kyphosis is a curve where you actually have a little bit of a humpback, which you see in osteoporosis. You can also get a scoliosis, which is a side-to-side bending. That's frequently evaluated during the early ages for both girls and boys by leaning over and touching the toes, and then seeing if one scapula rises higher than the other. That would indicate that there's a side-to-side or a scoliosis. And then you can have a lordosis where you actually have an increase in curvature of the lordotic spine. That we tend to see that more in pregnant patients, but there can be some patients with excessive abdominal obesity that'll sometimes have a lordosis, and that's called a sway back. So checking posture is important because that can give you an idea of overall tone, and it gives you an idea of symmetry and alignment as well. So some of the modalities that they go through quite a few in this chapter. Cryotherapy and thermotherapy are probably the more common things that you guys would be dealing with as far as medical assistants go. Cryotherapy is basically applying cold for therapeutic reason. That cold may be either wet or dry, or it could be chemical or natural. So there's different ways of applying it. Cryotherapy functions to cause vasoconstriction. So when we have vasoconstriction, we wind up decreasing the route of inflammation. We get decreased blood flow to the area, so swelling usually goes down. And so frequently with like a sprained ankle, anything that's starting to swell, a lot of times they'll use cryotherapy to try and decrease the swelling and inflammation. So there's good things and bad things with that. There is a little bit of a drawback because blood flow to an area that's injured brings chemicals that are healing and nutrients. And so it can be kind of a drawback, but when you have an acute injury, especially with something that's going to swell excessively, cryotherapy is usually used. When we go to thermotherapy, we're actually applying heat for some sort of therapeutic reason. That heat could be dry, like a heating pad, or it could be moist, just some sort of moist thermotherapy, like compress. So you can have different modalities depending on what you're dealing with. And so that heat can also have positive things. You can relieve pain and congestion. It does help with muscular pain and muscular spasms, so that's frequently why thermotherapy is used. So there are positives with that, but once again, we have to be careful too. There are some factors that can limit both of these usages, and we had talked about that in the geriatric chapter. When you have someone that's got very thin skin, either the very young or the very old, you have to be very careful with these therapies because the cold and the heat can affect the skin integrity. And so you also have to look at patients that have altered blood flow to extremities if you're using these treatment regimens on extremities, because that can cause an issue too. If you don't have good blood flow, then you can have problems with the skin and you can get skin damage from these modalities. So you do have to be careful with them. They have to be monitored. And so prototypically, you're going to limit cryotherapy usually 10 to 15 minutes and make sure there's some sort of barrier between the cold and the skin. You don't want to just throw straight freezing, straight ice on the skin because that can cause problems. Okay, so once again, these are the things to look for. Make sure your location. Make sure you know whether or not this patient has any impairment in their circulation or sensation. Know their temperature tolerance. Okay, and once again, the elderly, the very young, and the very old are very sensitive to cold and heat, and so you might have to lower the time frame, shorten it to make sure that there's no skin damage. Elderly will frequently, especially with low back pain, will just sit on a heating pad. So it's always important to ask if they've got some sort of pain, if they've been using a modality, and make sure to check the skin because sometimes they will overdo things. And so it's important to know that sometimes they will self-treat as well and to guide them and educate them on what's appropriate because we don't want them to hurt themselves. So we kind of talked about this already, but the principles of cryotherapy is basically to constrict blood vessels. The physiologic response to that is it will decrease swelling. That's the primary reason why you would use some sort of cold therapy. It does control bleeding, so if someone is bleeding excessively, there might be a case scenario you'd want to find a pressure point, but sometimes cryotherapy will be used to control or decrease bleeding. Ultimately, when you prevent swelling, you also reduce inflammation. So there's usually less swelling, less heat, and a little bit less pain. You can get a bit of an anesthetic effect from ice. It doesn't last very long, but it can have a little bit of a numbing effect. The reducing pus information basically just comes from the decrease in inflammation, and it will lower the body temperature of the extremity that you're dealing with. So once again, you can do ice bags, you can do collars. There's some chemical ice packs as well that are dry, but then you can also do cold compresses and ice massage. You can put, somebody needs to ice a knee or an elbow, especially if you're out in like a sports setting. You can freeze water halfway up in like a styrofoam cup, and then you can pull off most of the styrofoam cup and you can use it as kind of a massage. But you just have to be very careful not to overdo it and know your patient's vascularity and their age as well and what's appropriate. So the principles of thermotherapy, or using some form of heat, is that causes the opposite of cryotherapy, causes dilation of blood vessels. With that dilation of blood vessels, you usually get some sort of erythema in the skin, or erythema. And so the physiologic responses that come from that are reducing pain and congestion. You get muscle relaxation, decrease in muscle spasms, and then it can sometimes reduce inflammation and swelling. Although if something is acutely injured and you throw heat on it, it sometimes will swell excessively. So you have to be careful with using thermotherapy. If you've got somebody with rheumatoid arthritis, it's got swollen joints, and you put heat on them, sometimes it will make it worse. So it's important to know what kind of disorder that you're dealing with. So these just kind of go through some of the different ways that you can administer dry heat versus moist heat. The fluidotherapy that's listed there is sort of a specialized area where you have heated beads. It kind of functions as kind of like using heated water, but it is sort of a little bit of a different modality where you're heating up stones and using that for the therapeutic modality. And then there's also diathermy, which is under this area as well, and where you're using sort of high frequency waves to get deep heat penetration into muscles. Ultrasound, of these three, the ultrasound is probably the most common. There are ultrasound machines. We kind of prototypically think of ultrasound machines as being a sound wave that detects, it bounces sound waves off and can detect, the size of organs and what have you. But you also have some ultrasound machines that can deliver heat via ultrasound waves, and so via those sound waves. And so it's a little bit of a different module, but it can be used on specific muscular areas to increase deep heat penetration when you've got a lot of pain musculoskeletally going on. There are also shortwave and microwave types of diathermy that can be used. You just have to be careful. These are kind of limited to a certain time frame, and you generally can't use either one of these with patients that have pacemakers. But once again, the ultrasound is probably the most common on this list. Hydrotherapy is wonderful, and so it can be used to treat a number of physical problems. Once again, muscular aches and pains, which are very common, different types of arthritis. When you've got jets, when you've got warm water with jets, that the movement of water can be very therapeutic. It creates sort of a hydro massage, relaxes muscles. It can increase circulation, which can be frequently used even with people that don't have a specific injury, but just a lot of muscular aches. Some people will contrast these. Most people will stick with whirlpools or just like a jacuzzi type of setting. Some people will actually do a contrast bath where they'll actually have a hot bath and then a cold bath, and then move back and forth. And so some people do find the contrasts. Baths can be helpful. You have to be careful with your age group as well. You wouldn't want to necessarily do this for the elderly, but there are certain conditions where you can go back and forth between the hot and the cold, and that actually can stimulate improved circulation, which speeds up healing, and can sometimes help with greater mobility. But once again, this isn't for everyone. Okay, just swimming itself, when you look at underwater exercises, the nice thing is that you're dealing with buoyancy and it takes pressure off joints. And when people can't really walk very well because of knee or back issues, getting into a pool can be very therapeutic. And so you can do a lot of the same exercise regimens. You can jog in place. You can do a lot of things that you can't do on ground because of the buoyancy of water. And so underwater exercises are highly recommended for the geriatric population, people with a number of musculoskeletal conditions because of that. And so it's a really wonderful mode of exercise for many people that have some of these ailments. And so when we're actually looking at exercise therapy, you do have to be kind of careful because you're going to be kind of patient specific with these things. You're looking to not only increase muscle tone and strength, you're also wanting to keep them moving and keep them flexible. A lot of things come from patients, things hurt, and so they don't move, and so they don't want to do anything, and so then the muscles become a little atrophied and a little bit tight, and then it kind of creates this vicious cycle. And so getting patients to find something that they enjoy, that gets them moving and that will also help with strength and muscle tone is important. And so sometimes I'll go, well, I can't do this because I have knee pain, and I can't do that because I have arthritis, and I can't do this. And so a lot of them start, and I can't do that because I don't have access to it. So it can be kind of challenging because patients generally don't like, a lot of patients don't like to exercise. Some do, but some don't. And so trying to find something that's a balance that they enjoy, that's easy for them to do, that doesn't feel like they're working too hard can be a challenge, but being creative, knowing what their disabilities are, knowing what their strengths are, to try to set up some sort of an appropriate exercise therapy for them. Okay. So as a role here for you guys looking at the medical assistants, it's an information resource, knowing even just the local YMCAs, where the local pools are that they have, or public pools, knowing where they have places that are safe to walk, parks, gyms, knowing appropriate exercise routine. Sometimes people think if they go to the gym, they have to be there for an hour or 2 hours. You know, even 10 to 15 minutes of walking, 10 to 15 minutes of just easy 2 or 3 pound weightlifting is sometimes, you know, all that needs to be done. Obviously, you want to make sure that you're working in conjunction with the physical therapist and the primary care. You don't want to just suggest things out of the blue. Know what their issues are, but sometimes just being positive and giving them some ideas on things can be helpful, because sometimes they think they have to go out and do a long exercise. I sometimes just tell people, go for a 10-minute walk twice a day, go for a 15-minute walk twice a day, you know, as long as it's within their limits and what they can do, and then work from there. It's a matter of just trying to get them into the habit. If they can do something for 2 or 3 weeks or a month, a lot of times they'll feel better and they'll keep doing it. Okay. You got to be that cheerleader, that source of encouragement, and just tell them, even if they're, you know, just little things, even if they, yeah, I went for a walk 3 times this week, that's great. Okay, keep doing that, and then slowly work up. It doesn't have to be something that changes overnight. Okay. All right, so there's a number of different kinds of exercises, and once again, it is based on the patient's physical condition and their ailments. Active mobility are self-directed exercises where we're actually looking at increasing muscle strength and function. This might not be the appropriate thing for everybody, but these are exercises that are built at making sure that they're increasing, they're self-directed, and that they're actually increasing their own muscle strength and function. There are some case scenarios where people have enough muscle atrophy and enough disability that sometimes they have to just do passive mobility. There may be a situation where a machine has to move the body part, or a therapist. If people are in a bed and they can't get out, then sometimes just rotation, having them just sit up and get back down again, doing things that are within their capability. Sometimes they'll even just do range of motion exercises. Even just moving the muscles, and just even if someone else is doing it, can improve circulation. Okay. And so it's really important when you've got, especially the geriatric population, where they sometimes just get in the habit of just sitting and not doing anything, trying to just get them to do some, you know, range of motion exercises, maybe just some light weights, 2 or 3 pounds, you know, just doing some basic stuff can be helpful. Okay. And then there are some case scenarios where we have aided mobility, and these are self-directed, and they may be a situation where you're having to use a device of some sort. And once again, looking at range of motion exercise, people that are in wheelchairs, you know, getting them to do what they're capable of. If they are a paraplegic and they're in a wheelchair, then just make sure they're not sitting all the time, that they actually can get themselves out, and that they're doing enough upper body. You know, a lot of people A lot of people are now, I have a friend that's in a wheelchair, but she still plays tennis. And so just encouraging them to get out and doing something that's within their capability. Okay. Active resistance exercises where you're actually working against resistance. You don't even have to, even just somebody putting a little bit of light pressure when you're doing a bicep curl, you don't even have to use weights. You can just, just putting a little bit of resistance works those muscles, okay? Isometric exercises are actually when you have your leg in a fixed position. Let's say your leg is straight, and then you contract your quad and then relax, and contract your quad and then relax. Same thing with other muscles, your abdominals. You can actually increase your muscle strength just by doing isometric exercises. So there are case scenarios where people might be in a situation where they can't stand, or they can't completely do, they can't do some of these more active exercises. Even isometric muscle movement is important to do. Okay, and once again, you can split your range of motion exercises into active or passive. And if someone is bedridden, then you might have to have something where they're assisted. Okay, but even passive range of motion exercises helps muscular strength and circulation. There's also something called a TENS unit, where you can actually give a little bit of electrical stimulation. It gives just a little bit of low voltage, like a low voltage contraction, and then it can actually stimulate the muscles to contract. That can even prevent atrophy by using this. So there's certain case scenarios, even before a chiropractor does any chiropractic manipulation, sometimes they'll use a TENS unit, or if there's a situation where you've got decreased usage of a particular limb or what have you, they can use TENS unit to kind of stimulate the contraction, and it can actually help to retrain and increase the strength in muscles that haven't been used for a particular injury. Massage can also be very beneficial. There's a number of different kinds of massage techniques that are there. There's light massage, there's deep tissue massage. So obviously you have to look at what you're dealing with as far as the patient goes. Some of the effects can be decreasing stress, working out muscular tension. It can reduce heart rate and blood pressure. It can help people sleep better. There's a lot of benefits coming from massage. It increases circulation, lymph flow. The book talks a little bit about Swedish massage as well. Neuromuscular massage kind of focuses on specific muscle types and also relieves pain and pressure on the nerves more specifically than just muscles. So there's a number of different massage techniques, and massage maybe isn't going to be for everyone, but there are certainly a number of musculoskeletal situations where massage can be a huge benefit. Traction is where we're actually just pulling or stretching on the musculoskeletal system. What that can do is kind of help put the bones back in alignment. And there's a number of different kinds of tractions. Especially when you're dealing with the vertebra, sometimes doing some traction on the vertebra can actually provide space in the disc area and can kind of actually help alleviate joint tenderness and even kind of help stretch out muscles. There can be reduced tension by doing traction, and it's very gentle. We're not talking about heavy traction, but it can increase range of motion and decrease joint and muscle stiffness with traction in certain areas. The cervical area, pulling on certain limbs can be of benefit. They talk about 3 or 4 different types in the book, I believe, as well. There are times where you can actually use harnesses and weights. Sometimes if someone has a broken leg, they'll actually have to use a type of traction that actually makes sure that as the bone heals, that it doesn't heal too short. So there are times where you can actually do skeletal or mechanical traction that actually is weighted areas that pull to make sure that something heals. But you can also do it manually for something that doesn't involve a broken extremity. So once again, static does have its place depending on what kind of injury you're dealing with. So when we look at some of the aids that you guys will be dealing with, it will depend on what their to choose. Appropriate aids will depend on their disability, their coordination, their strength, and their age. Okay, so you always want to make sure it's age appropriate. Obviously, you're not going to be making the choice, on what's being used, but you may have to demonstrate to these patients how to use their mobility aid depending on what it is. So we look at canes. Canes are very common. There's a standard type of cane. Some of them are tripod where they have three contacts to the ground. Some are quad base that have 4. Those tend to stand on their own. There's some other prototypical canes that just have sort of a grip on the bottom and they're straight down and they're not a tripod. And so knowing what that patient needs is important. The tripod and the quad are nice because they actually will kind of stand on their own. The other types of regular canes obviously prototypically won't. So you want to make sure it's the correct height. You want to bend your elbow to about 20 to 25 degrees, and you shouldn't lean on the cane for excessive support. You shouldn't be too much on that cane. It's just supposed to help provide extra support if you have a limb that's, one side of your body is a little bit weaker, the muscles are weaker, just for some extra support. Okay, and so you wouldn't want to put somebody that's non-weight bearing on one to be using a cane. These are frequently just older individuals whose musculature isn't as good, or even post-stroke where one side is weaker than the other. A cane can be appropriate. Walkers should be used by patients who can walk but have balance problems. Okay, so generally they sometimes can go short distances alone, but they can't go long distances, and so they really do need to have just some extra support as they're going. Once again, it's muscular weakness. It kind of gives them a sense of stability. It does need to be appropriate for the height of the patient. Most of the decent walkers will hold sometimes up to 350, and they have even a seat, so a patient could walk with it. There's a brake, usually a double-sided hand brake, and a flip brake to keep it steady, and then there's an area where they can actually sit, and so it gives them a sense of just a sense of extra stability, and then even a place to sit if necessary. Okay. Crutches are obviously common. These are usually more common post-injury, sprained ankle, sprained knee. The key with crutches is that you got to make sure they're sized correctly, and you're going to be there. The book talks about some different kinds of walks. It talks about a 4-point walk or a gait, a 3-point gait. And so prototypically this is going to be like a 3-point gait because you have an individual that's usually non-weight bearing. You might have somebody in a boot who can put some pressure down, which would be like a 4-point gait, but prototypically this is someone who's got an injury where they're going to be at least non-weight bearing for a particular length of time, and so they're going to have to coordinate a 3-point gait, which is demonstrated in the book, and this will be one of the things that the physical therapy students talk to you about, where you actually have a patient that can bear full weight on one leg but not the other, and then you're using the 2 crutches instead of the affected leg. So sizing is important. You got to make sure that you have 2 to 3 finger widths from the armpit to where the top part of the crutch comes, because otherwise you can get a nerve palsy in the armpit, and so you want to make sure your elbows are flexed about 30 degrees more or less. And you're going to want to make sure that they're about 2 inches up and out from each foot as you're going. You don't want to have them too far, because then it will put too much pressure on the armpit. So you want to make sure they're not too long, but you want them not too short either, because then you're unbalanced and it can cause lower back pain as well. So sizing is important. Okay. And then once again, you can do a tripod standing. That's kind of and they'll go through this in class. You want to make sure that as you take steps that they're inappropriate, because otherwise if the crutches are too wide or too close, you're not going to be balanced, and that can cause an issue. So when you're looking at crutches, you could use a 4-point gait, and these are usually people that are going a little slower, but they can bear weight on both legs, okay? And so they will go through and use the crutches as sort of an extra balancing point, but this tends to be one of the slower gaits, okay? 3-point gait is probably a little bit more common with crutches because you're looking at some sort of injury where you can't bear weight on one leg. This does require good muscle coordination and arm strength. Okay, you can't go very far if your upper body's not strong, and so that's why this gait may not be appropriate for everyone. Depending on the case scenario, an elderly would probably have a difficult time. An elderly person might have a difficult time with crutches, so it's possible that a different modality would have to be given to the patient if they have a case scenario with that. And then there's a 2-point gait, which is like a swing gait. Sometimes people that have some sort of disability, like a congenital disability, will use this where they actually swing forth. A lot of small people or people that are short stature that have limb issues will sometimes use this 2-point gait, and it's sort of what they call a swing gait. Okay, there's a swing to and a swing through, and so I don't know if they're going to be dealing with this too much in class, but just make sure you kind of read through the book on that. And then wheelchairs, the biggest thing that we'll be kind of dealing with this is actually getting patients from a wheelchair onto the table and back again. So they will show you how to safely move and maneuver these kinds of patients. And so there are different kinds of wheelchairs. There are some that people have to use their upper body and actually move the wheels. There are other types that are electronic or electrical. Sometimes they have electric scooters. And so it will be important just to make sure to learn how to do the transferring. And this is actually from Module 38, I believe, or from Chapter 38, 38-4. And so that particular procedure page will be included with this because that's where the wheelchair transferring is located. And then obviously, in order to see a physical therapist, a patient has to be referred, just like most other specialists. They have to have a referral. And so a physician's going to have to actually write an order and then make sure the patient has an information. A lot of times you actually have to write it on a prescription pad, and I've seen that before, and the doctor or clinician will say this patient's got, needs certain therapy post-injury, and then they'll advise them to go twice a week for 4 to 6 weeks, and that's a common time frame. And so it's important to make sure that the orders are transferred so that because the physical therapist they can decide whether or not the patient needs to be extended, and they can say, yeah, this patient's improving, but we think we need another month with them. But generally they can't. They have to know what the diagnosis is, and then they have to be given a certain time frame as far as what needs to be done. They are independent practitioners. A lot of them will work in a hospital or clinic, but they usually have to have some sort of direct order or referral from a clinician before starting things. You can't just say, oh, I have this problem and I'm going to go there. They usually want some sort of an order from a doctor. And once again, you guys might be facilitating that. Okay. All right. So once again, this is generally a fun experience having the PTA students come over, and so this once again is a specialty chapter because we're dealing with physical therapy, but some of the modalities in here you'll be dealing with because of the types of patients that you see in primary care. So just being familiar with this chapter, some of the different exercise routines, and some of the different modality aids that we'll talk about, mobility aids, as far as being able to guide someone on how to use a crutch or crutches, how to use a cane, how to use a walker, and then how to transfer patients safely from a wheelchair. It's going to be the biggest things that we need to take from here. There are a lot of other things, the therapeutic modalities that are discussed here, cold, heat, hydrotherapy, massage, and traction are all important, and you may see those modalities depending on what area you work in. Always take into consideration the patient that you're dealing with. Remember, we talked about how you have to be careful with peds patients and especially geriatric patients with their skin, with heat and cold, and then making sure we know their nerve intervention and their vasculature, because if they don't have good vasculature, their skin's not going to respond as well to these things. So just making sure you're careful with those patients, okay? All right, so we're signing off for Chapter 54, and we'll see you in class for the Fun Modality Day, that PT Collaboration Day.